Hello, and thank you for joining this OncLive peer exchange titled Immune Therapy Use in Advanced Urothelial Carcinoma. The advent of novel immunotherapies has revolutionized the field of oncology and is a particularly welcome addition to multimodality treatment of bladder cancer. Aggressive bladder cancers are challenging to treat, and until the recent availability of checkpoint inhibitors, patients with progression of metastatic disease on platinum-based therapy had few options. In this OncLive peer exchange discussion, we'll discuss what we know today about integrating immune therapy to the current treatment strategy and emerging data that we anticipate will shape the way forward. I'm Dr. Daniel Petrylak, and I'm a professor of medicine, medical oncology and urology, director of the Prostate and GU Medical Oncology Program, and director of translational prostate cancer research at Yale University Cancer Center in New Haven, Connecticut. Participating today in our distinguished panel are Dr. Dean Bajorin, attending physician at Memorial Sloan Kettering Cancer Center and professor of medicine at the Weill Cornell Medical College in New York, New York. Dr. Arjun Balar, assistant professor of medicine and the director of genitourinary medical oncology at the Laura and Isaac Perlmutter Cancer Center of NYU Langone Medical Center in New York, New York. Dr. Robert Dreicer, associate director for clinical research and deputy director of the University of Virginia Cancer Center and professor of medicine and urology at the University of Virginia School of Medicine in Charlottesville. Dr. Elizabeth Plimak, chief of the Division of Genitourinary Medical Oncology, director of genitourinary clinical research, and associate professor for the Department of Hematology Oncology at Fox Chase Cancer Center, Temple Health in Philadelphia, Pennsylvania, and Dr. David Quinn, medical director of USC Norris Cancer Center Hospital, head of a section of genitourinary medical oncology and associate professor of medicine in the Division of Oncology at the Keck School of Medicine of USC in Los Angeles, California. Thank you for joining us, and let's begin. So segment one is rapidly evolving paradigms for the treatment of muscle-invasive bladder cancer. And first, I'd like Dean to provide a historic perspective on the treatment of advanced bladder cancer and the potential for immune therapy in this setting, and what's known about the genetics and the heterogeneity of bladder cancer.
Thanks, Dan. It's a pleasure to be here. I think what we will do is start with advanced disease or metastatic disease, because that's really what most of our audience are seeing on a regular basis. And what we know in terms of advanced disease for patients who have metastatic disease is that we typically will split them into two different populations of patients. Cisplatin historically has been the foundation for metastatic disease treatment. We know that it's potentially curative, and there are a number of combinations that we all use, MVAC, gemcitabine plus cisplatin, et cetera. And we know that depending on the subset, the average or the median survival is roughly around 14 to 15 months in those patients. Long-term survival, however, we know depending on the subset is 5 to up to 15%. But in terms of long-term survival, this is a highly lethal disease, even with the best of therapy that we have. Then we have the patients who have who really don't qualify for cisplatin-based therapy. And that's a substantial population of patients, actually. The elderly, those who have renal insufficiency, cardiac disease, et cetera, those are actually have problems with hearing. And for most of those patients, we're using carboplatin-based regimens. And the typical one that we will use will be carboplatin plus gemcitabine. There's been a randomized trial showing that that should be if not the standard of care historically. But if you really look hard and fast at the data, median survival is about 9 months with those patients. And historically, we really don't see any long-term survival in those patients at all. And then we get into second-line therapy. Since most of the patients, their disease will have progressed after first-line therapy, historically that's been the space for the use of chemotherapy. In the United States, up until recently, we had absolutely no approved disease treatment for that state of disease. NCCN guidelines and other guidelines recommended taxanes and even pemetrexed, for example. But if you look at the response rate, it was 10% or less. The median survival is roughly around 6 to 8 months. And long-term cures were simply unseen. And so the metastatic disease setting really is an area of critical unmet need and is poised for new therapies. Then we have the second disease state sort of moving down, would be the muscle-invasive disease without metastasis. Standard of care really evolves around a management that includes cystectomy or management that is a bladder preservation approach. So those that include cystectomy, probably the gold standard that we all talk about is neoadjuvant chemotherapy followed by cystectomy and pelvic lymph node dissection. And we know that chemotherapy can play a major role there, and as does the cystectomy. And that can be curable. But if we look at the patients who don't respond well to chemotherapy and have residual disease after this type of approach, we know that they actually don't do well, that they actually have a high likelihood of relapse and death from disease. And then we have the patients who we may consider bladder preservation in, and that's usually considered trimodality therapy, where we do an aggressive transurethral resection. We give the combination of chemotherapy and radiation. We preserve the bladder as best we can. And the data are typical that around 50% of patients will survive 5 years roughly, and that about 35 or so % of patients will be able to preserve that bladder, and it'll be highly functional. And then the last group are the patients that in whom cystectomy is warranted, but do not qualify for cisplatin-based neoadjuvant chemotherapy. Cystectomy alone would be the standard of care there, and in point of fact, that survival actually can be quite limited as well. And so there is another area of critical unmet need, both in the perioperative setting and in combined therapies. And then the third disease state that we are now seeing more commonly on the medical oncology side is the old superficial disease, the non-muscle invasive disease, the TA, the T1, carcinoma in situ. And we typically don't see them, and there are subsets that do better and some sets that do worse. The one that is actually drawing the attention of the medical oncologists and new therapies are the so-called Bcg unresponsive patients. These are patients, the standard of care is resection for high-grade disease, and then Bcg is given on 6 weeks successively with maintenance for the majority of patients, and that can be highly curative. But the patients who do not respond well early on, within that first 6 months or a year, what are now used to be termed the Bcg unresponsive group, or the Bcg refractory as well, those patients actually do quite poorly. And that is an unmet need. And in fact, the FDA has identified that as an area in which drug development is really necessary. And in fact, doesn't even warrant randomized trials because of the high lethality of that patient population. So then we get into the issue of BCG is a highly active immune therapy. In point of fact, actually, bladder cancer, in general, is highly active in terms of its sensitivity to early immune therapy. We know from years ago. So, in terms of the question asked about the high number of mutations and clonality, we know from studies now that we have the TCGA and other studies, we know that there is a substantial number of mutations that we see in this disease. And in fact, the mutation rate is right up there with non-small cell lung cancer and melanoma, a high number of mutations. And if we actually look at studies that look at the primary tumor and metastatic disease, there's even more mutations in the metastatic disease setting. And in fact, we expect that there's an evolutionary sort of clonality of these mutations over time. So in fact, metastatic disease might be quite sensitive based on that mutation rate. So I think we're well poised in terms of areas of unmet need in all 3 of these disease states: the metastatic, the muscle invasive, and the non-muscle invasive. We have a disease that has a high mutation rate. It's poised for sensitivity to immune therapy. And then we also have a history of immune therapy being active. And then if we look at biopsies, we see, for example, there's tremendous lymphocytic infiltration. So we know that some of these tumors are highly recognized with regard to immunotherapeutic interventions.
And let me just add one thing. From a societal perspective, bladder cancer, 10 to 15% of all bladder cancers in the U.S. don't get treated at all. And part of this is a reflection of the difficulty, the tolerability of therapy. So as we talk about immune-based therapies, there's the potential to actually reach a large group of patients who are undertreated.
Yeah, and a disease in the elderly that really need tolerable therapy.
Absolutely, a very, very heterogeneous disease as well. In fact, you were the